Hello, my name is Dr. Amgad Makaryus, a cardiologist with the Northwell Health System in New York, USA. I'd like to share with you today an article we recently published in Reviews in Cardiovascular Medicine. My colleagues, Dr. Gala and Dr. Boutros, and I published an article titled The Beneficial Effects of Glucagon-Like Peptide-1 Agonists on Blood Pressure, a Comprehensive Review. In this paper, we explore how glucagon-like peptide-1 receptor agonists, the GLP-1 RAs, impact blood pressure and cardiovascular health, especially in patients with diabetes and obesity. Now, why this is an important topic is the fact that hypertension is actually, as we all know, a major cardiovascular risk factor and often coexists with type 2 diabetes and obesity. We know that GLP-1s were developed for glycemic control, but evidence has been growing to now show that they also deliver broader cardiometabolic benefits, namely weight loss, improved endothelial function, reduced inflammation, and modest blood pressure reductions. And this is the focus of this paper. There are multiple proposed mechanisms of action for reducing blood pressure, and they start with, number one, vascular effects. The GLP-1s enhance endothelial function and promote vasodilation via nitric oxide pathways, improving large artery compliance. Now, this mostly affects systolic blood pressure. Second mechanism is autonomic modulation. While the GLP-1s can slightly increase heart rate about 2 to 4 beats per minute, outcome trials have actually shown no harm with respect to this, and the overall net effect is that of blood pressure reduction. Number three, the third mechanism, is renal mechanisms. So GLP-1 receptor activation in the kidney promotes natriuresis and diuresis and may dampen the renin-angiotensin-aldosterone system, thereby lowering plasma volume and vascular resistance. And then finally, and the mechanism that most people look at and are familiar with, is that of weight loss. Significant and sustained weight loss improves insulin sensitivity, reduces inflammatory cytokines, and lowers sympathetic tone, all of which are key drivers to blood pressure reduction. Now, importantly, some blood pressure benefit appears even before major weight loss is realized, suggesting that there is, aside from the weight loss, a direct effect as well. So these mechanisms have actually been studied in a number of trials and are continuing to be studied in many further trials. So the first trial that we detailed in our review paper is the LEADER trial. The LEADER trial looked at liraglutide, and it found that there was a 13% reduction in major adverse cardiovascular events with modest systolic blood pressure, about 1.2 millimeters of mercury. The second trial is the REWIND trial, and this looked at dulaglutide, and this trial showed a 12% reduction in MACE with systolic blood pressure down about 1.7 millimeters of mercury with a strong signal for stroke reduction. The third trial is that titled SUSTAIN-6. This looked at semaglutide, and this showed a 26% reduction in MACE with a systolic blood pressure reduction of about 2.6 millimeters of mercury alongside the weight loss that was realized. And then finally, another trial that we highlight is the SURMOUNT-1 trial. This trial looked at tirzepatide in obesity without coexisting diabetes, and they found a large weight loss and a more pronounced blood pressure reduction, a systolic blood pressure reduction of about 6 to 7 millimeters of mercury, and a diastolic blood pressure reduction of about 4 millimeters of mercury. So how do the GLP-1s compare to traditional hypertensives? Well, the answer is, compared to the traditional standard agents that we use, like ACE inhibitors, ARBs, thiazides, calcium channel blockers, those typically reduce systolic blood pressure by about 5 to 15 millimeters of mercury. So as you can see from the studies that I just detailed, the GLP-1s actually lower it to a lesser degree. So that being said, that means the GLP-1s are not a replacement for dedicated blood pressure therapy when substantial lowering is needed. However, they can provide an additive cumulative blood pressure benefit on top of pre-existing evidence-based treatment for hypertension. And they can be especially valuable for patients with obesity and diabetes, since they target those other pathways as well, while simultaneously improving weight gain, glycemia, lipids, and inflammation, and thereby also causing an added benefit to lowering of blood pressure. So the guidelines are still being worked on with respect to hypertension, but some of the takeaways we can take with this is that the GLP-1s have proven cardiovascular benefit. And the ones that I named, the liraglutide, semaglutide, dulaglutide, are all recommended for type 2 diabetes patients with established atherosclerotic cardiovascular disease or high cardiovascular risk, irrespective of the hemoglobin A1C. They are best used as an adjunct to standard antihypertensives when the therapeutic priority is comprehensive cardiovascular risk reduction. There is also considerable tolerability and cost. So the GI side effects are uncommon during initiation, and these agents, although are still on the expensive side, so therefore we have to target them pertaining to their other indications as well, and take that into account when we as physicians prescribe them. The bottom line is the GLP-1 receptor agonists are modestly reducing when it comes to blood pressure, but their real value is actually multifactorial, combining weight loss, metabolic improvements, renal and vascular benefits, and proven cardiovascular risk reduction. For patients at the intersection of hypertension, diabetes, and obesity, they offer a powerful, holistic strategy to lower overall cardiovascular risk. And of course, further studies are needed to further clarify long-term blood pressure effects and refine patient selection for maximal benefit further than we have today. I thank you very much for your attention.